laparoscopic eTEP RS, reef stopper, by optical entry, and preperitoneal Carolina's crossover technique for incisional hernia in a 31 years old female who has had two previous cesareans, laparotomy for ectopic pregnancy and laparoscopic cholecystectomy, and now she has presented with large divarication of recti and infra-umbilical incisional hernia.
सिर ऊपर, खांसी, छोड़ो, खांसी.
On standing position, one can appreciate the defects, especially on the right side. And the CT scan revealed multiple Swiss cheese defects in and infra-umbilical incisional hernia. The defects were of the size of 8 by 8.6 into 4.2, and the sac was 5.8 into 6.4 centimeter. There was a diastasis craniocortically 16 centimeter, and recti distance was of the order of 11 centimeters. So patient was prepared, optimized, and taken up for eTEP restopa technique by Carolina's crossover, and we believe on optical entry. By standing on the left side of the patient, we start the eTEP RS. One can appreciate on the table also
दोनों टांगों को ऊपर करो.
the divarication as well as the hernia.
उठाओ. हाँ, very good. और उठाओ. हाँ, नीचे करो. अब गर्दन
We
को उठाओ.
stand on the left side of the patient, and the two monitors are on the right side. We take the bariatric length optical trocar 15 centimeter, and we go medial to the linea semilunaris with the help of 10 mm 0 degree scope. We rotate by 360 degree skin, subcutaneous tissue, campers, scarpa, and then we are able to see the left anterior rectus sheath. With 360 degree rotation, we carry on moving in, and as soon as we see the left rectus abdominis muscle, then we slow down and we are able to see the posterior rectus sheath. And then we change the angle and graze over the white glistening posterior rectus sheath of the left side, and then carry on doing the blade dissection after creating a pneumo-extraperitoneum to a pressure of 15 millimeters of mercury. The beauty of optical trocar is that we are able to see every layer, every small single vessel, and then we carry on grazing over the posterior rectus sheath and desiccating the loose fibrofatty tissue. Once we have created the space, then we change to 10 mm 30 degree scope, and then we place two more ports on the left side. First secondary port is placed 6 to 8 centimeters away from the first optical entry, which is quite close to the first was close to the subcostal margin, and now the first secondary port is a Lena threaded 5 mm port, and we test it first with the syringe and needle, that is, I call this as GPS, and then we place the artery forceps to break open the muscular layer, and then with the help of 5 millimeter trocar, we go in without causing any injury to the neurovascular bundles, and we place the port, and then with single-handed technique, means with the help of harmonic incision or sonicision, we do the dissection over the posterior rectus sheath, the white glistening surface, white glistening membrane, one can see beautifully. And then we carry on making the space with the help of harmonic A's, and we go from the cranial side towards the caudal side. Aim is that remain close to the posterior rectus sheath, and as we make a space for the second secondary port, we again use the syringe and needle to find out the exact location where we are not going to injure the left inferior epigastric vessels or the neurovascular bundles, and then we make the entry for the second secondary port, again 6 to 8 centimeters away from the first primary port, secondary port. Our thinking is that for eTEP RS, we make only 3 ports. One is 12 mm and 2 are 5 millimeter, and all of them are on the left side once the patient is having a hernia, especially on the right side. But if the hernia is on the left side, then we make the retrorectus space on the right side, and then we make the 3 ports on the right side, so that the monitors are placed across, so that we are able to do the dissection for Carolina's crossover. Now one can see that 3 ports have been placed on the left side, and with the help of Sony season or harmonic A's, we carry on desiccating the loose fibrofatty tissue and take it towards the rectus muscle. Yes, one can use the hook also, but we have a liking for using the ultra season or Sony season. And here one can appreciate the pulsation of inferior epigastric vessels, so we should not injure the inferior epigastric vessels. And then we carry on moving caudally towards the pubic ramus, pubic bone, and we go 2 centimeters into the cave of Retzius for the further placement of the mesh. Once the cave of Retzius has been dissected, then we start moving with inferior crossover and go towards the right side. But only challenge is that one should always remain preperitoneal rather than pre-fascia transversalis even. So we remain close to the single cell thick peritoneum, and at this stage now we change the scope to 5 millimeter, and from the subcostal region we go in the first secondary port, and then we carry on making the retrorectus space on the left side up to the xiphoid process. And we start with giving a incision on the posterior rectus sheath 5 millimeter to 1 centimeter away from the insertion of the posterior rectus sheath, close to the medial margin of the left rectus abdominis muscle, and only the sheath is incised, and we create long space for the falciform ligament to be identified, and then falciform ligament to be taken down. Again, in this situation, because we are not going to incise the posterior rectus sheath on the right side, so we make sure that we have taken the falciform ligament down, and then we are doing the preperitoneal dissection for Carolina's crossover. And with gentle caressing movements, we take the peritoneum as well as the fascia transversalis down and reach up to the subcostal region on the right side, care is taken, one can appreciate that it is a very thin single cell peritoneum. So one should be very, very gentle, very, very careful that we are not going to injure the peritoneum. And as we take the preperitoneal dissection on the right side, so we can go quite laterally for the mesh to be placed more in the subcostal region. And once enough of space has been created, then we start moving towards the area of the defect. Again, intention is to remain preperitoneal, means we do not want to injure the right posterior rectus sheath, we do not want to injure the linea alba, but we remain, and with the caressing movements we remain in the preperitoneal space, desiccate the tissues down. And as we are nearing the area of the defect, we not intentionally but intentionally also one can give a small incision on the peritoneum so that we are able to see within. Means, if for example intestines are adherent or the omentum is adherent, so we can appreciate the adhesions, and then we do the adhenolysis, making sure that we do not cause any iatrogenic enterotomy. Our thinking is that there is a snake behind every bush, and even a small snake can be lethal. So we should make sure that eyes don't lie, means we are able to see intraperitoneally also through that small rent which had been caused, and then we are able to see whether only the omentum is going into the hernial defects or the intestines are also going. So we remain in the preperitoneal space, taking care of the posterior rectus sheath fibers which are inserting on the linea alba. Again and again, the caution is that we should not injure the linea alba, we should not weaken the linea alba, and we should remain in the preperitoneal space. And with the help of harmonic A's, we are able to remain close to the medial border of rectus abdominis. We should not cause any injury to the medial border of rectus abdominis on the left side. We should not cause any injury to the rectus sheath on the right side. Linea alba crisscross fibers can be appreciated on the top, and we are remaining in the preperitoneal space. Slow is fast, fast is slow. Means we carry on taking the fascia transversalis as well as the peritoneum down, and now we are going from cranial side to the caudal side, and aim is to reach up to the pubic ramus or the pubic space, retropubic cave of Retzius, and we take the posterior rectus sheath 5 millimeter to 1 centimeter away from the medial margin of the rectus abdominis without causing any injury to the linea alba. And one can appreciate the defect inside the peritoneal cavity, and there are multiple defects, and this is we had seen on the CT scan also that these are the Swiss cheese defects, and endeavor is to remain in the preperitoneal space, and thinking is that we should try to preserve as much of peritoneum as possible, because at the end we are going to close the posterior closure or the peritoneum and the posterior rectus sheath on the left side. So we should be very careful that even if we cause a small peritoneal rent, they have to be closed so that our polypropylene mesh which we are going to place in should not come in contact with the intestines and cause unnecessary subacute or acute intestinal obstructions in the immediate or late post-op period. So one should be very, very careful, very gentle when we are working close to the peritoneum and when we are working close to the posterior rectus sheath on the left side. And we are going to use this posterior rectus sheath on the left side and the peritoneum on the right side to close the peritoneal rents. And one can appreciate the omentum is going into the multiple Swiss cheese defects, and we remain as centrifugal as possible so that we do not leave the omentum in the defect, and we do not leave any, try not to leave the sac also in the defects, so that the chances of seroma formation are reduced to minimum. And trick is to remain in the preperitoneal space. Small bites, small mistakes. So with the help of harmonic or even with the help of hook, so one can carry on descending down. Most of the times we prefer harmonic ace or sonicism because of the less amount of smoke created as compared to monopolar hook or bipolar cautery. And one can see that we are reducing the omental contents down, remaining close to the linea alba, close to the defects, Swiss cheese defects. Multiple defects can be appreciated. And intention is to go into the space which we had created at the time of insertion of the second port that we did the inferior crossover. So we start from cranial side, carry on moving towards the caudal side, and then meet in the center in the in the space of Bogros and in the cave of Retzius, so that all the peritoneum has been taken down and all the defects can be seen on the linea alba, just with gentle caressing movements, and we should make sure that we are not going to injure the linea alba. Remain as centrifugal as possible. Many times, many surgeons believe that eTEP means that staying only in the extraperitoneal space. No, our thinking is once we have created these spaces, then we should definitely go intraperitoneal to see for any intestinal adhesions and do the adenolysis under vision, and then once the adenolysis has been done, then completely close the peritoneal rents so that we are not going to have any iatrogenic entrotomy and cascade of events later on. One can see beautifully the preperitoneal dissection, and peritoneum is a single cell thick layer. With the help of suction irrigation cannula and using it both end on and side on, one can do the blunt as well as the sharp dissection, and we carry on going towards the caudal side, that means the pubic ramus and the pubic bone. Again, we are able to appreciate the omentum going into the multiple Swiss cheese defects, remaining close to the linea alba and in the preperitoneal space. Traction and counter traction are necessary for this kind of dissection. And one can appreciate the right rectus muscle on the top, preperitoneal dissection on the right side. And hemostasis is well maintained. And once we have done a craniocaudal dissection, then is the time that we are going to close the peritoneum and the posterior rectus sheath defects on the posterior aspect. One can appreciate multiple Swiss cheese defects. And a large divarication. We should fix the bleeders there and then. We should not work in the puddle of blood. So as soon as a small bleeder is there in the omental adhesions, we should fix it there and then rather than repenting later on. One can see the crisscross fibers of the linea alba on the top, and all around the defects we take the peritoneum down so that when we are going to close the defects, and then we are going to place in the mesh, we should have given a good overlap of more than 5 centimeters all around the defects for recurrence free hernia repair. multiple defects. Slow is fast, fast is slow. And with the help of, as I mentioned, with the help of suction irrigation cannula, we just remain in the preperitoneal space, carry on doing the preperitoneal dissection, down, down, and down, and go on to the contralateral side for good overlap of the defects with the mesh later on. The patient has already been catheterized, so one should be very careful in the area of the pelvis into the pre into the cave of Retzius, so that we do not cause any injury to the bladder also. And the injury to the muscles also, the right rectus muscle also has to be prevented. It should not be, the fiber should not be broken. And again, intention is to remain in the preperitoneal space with gentle traction and counter traction. We are able to maintain that space. One can appreciate the rectus muscle on the top, the right rectus muscle on the top. Peritoneum is being dissected off. And our end point is that when we are able to see the Cooper's ligament, we are able to shake hands from cranial side to the caudal side up to the cave of Retzius. That will be our end point. Again, in the same preperitoneal space of Bocros that we are reaching. And we should not cause any injury to the right inferior epigastric vessels also. So one should be careful at this area. Preperitoneal dissection with the help of end-on suction irrigation cannula. And the advantage of Carolina's crossover is this, that we do not injure the neurovascular bundles on the right side. We do not give an incision onto the posterior rectus sheath, but we can go quite far off on the right side for the proper mesh placement in the preperitoneal space on the right side and retrorectus space on the left side. Now we close the posterior defects of peritoneum and the posterior rectus sheath of the left side with the help of PDS barbed absorbable suture with 37 needle, and we start from distal most side towards the cranial side, making sure that we close all the peritoneal rents. At this stage, we reduce the pneumo-extraperitoneum or pneumoperitoneum to 6 to 8 millimeters of mercury so that there is no tension on the posterior rectus sheath and peritoneal closure, and we are aware of the PRS disruption if the in the post-op period if the suturing has been done under tension. So we should be very careful that we reduce the pressure and we take small bites, and we do not want to see the PRS disruption in the post-op period. And we close all the peritoneal rents so that the intestines do not come into contact with the proline mesh or polypropylene mesh which we are going to place in this space. And then we do the anterior closure with the help of non-absorbable PBT suture and number 2. And again we start from from the caudal side and carry on moving towards the cranial side, making sure that one, we are not taking the muscles, we are taking the sheath. 2, we go through the linea alba also at places so that the chances of seroma formation are reduced to the minimum. And then on the contralateral side also, we do not want to go into the muscle, but we believe on facial closure and medialization of the recti. And we have taken 45 centimeter barbed suture on 37 needle, and we carry on moving from caudal side towards the cranial side. And many times if we have to take another suture from cranial to caudal for closing the complete divarication, we do not hesitate at all, and we close the long divarication and approximate the fascia and medialize the both the rectus abdominis for good abdominal wall reconstruction. If the linea alba, the defects are restored well, that is the advantage of AWR rather than IPOM if we would have done it. And we always manage what we do not, we measure it. So umbilical tape of 30 centimeters taken, and we measured the supposed length and breadth or length and width of the mesh which we are going to place in. So in this situation we have used the peritene polypropylene 46 gram per meter square mesh, and we double fold it. And once we double fold it, and the trick is that we push the mesh by pushing the bariatric length trocar into the wound as much as possible, and then placing in a mesh and then withdrawing the cannula so that double folded mesh rests absolutely comfortable in the space. And then we deploy it from south to, that means the cave of Retzius, to north, that means xiphoid process, and from left side and right side, so that the good coverage of the defects is done. And we close the defects and then patient is allowed to go home after 24 to 48 hours once the patient passes motion. Thank you very much for your kind attention. Thanks a lot.